Welcome to Chronic Migraine in Primary Care. We're glad you're here. My name is Angie Hunt, Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC Government, as well as donations and memberships to WWDPI. We thank our program partners, Pain BC, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We will collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You'll be emailed the direct links for all these items when they are available. As I mentioned, my name is Angie, and I'll be moderating the webinar and Q&A session. Our presenter today is Dr. Werner Becker. Dr. Becker is Professor Emeritus in the Department of Clinical Neurosciences at the Cummings School of Medicine, University of Calgary. He received his medical degree from the University of Manitoba in Winnipeg and did his neurology training at McGill University in Montreal. He is a past president of the Canadian Headache Society and has served on the boards of the American Headache Society and the International Headache Society. Dr. Becker founded the Calgary Headache Assessment and Management Program, a multidisciplinary headache management program in Calgary in 2003. He was awarded the John R. Graham Award for Research and Education in the Field of Headache by the American Headache Society in 2011 and the Alberta Medical Association Medal for Distinguished Service in 2013. Dr. Becker has over 100 peer-reviewed publications and was senior author on 2 national Canadian migraine treatment guidelines. And now I'll hand it over to Dr. Becker.
Thank you, Angie. Well, today's topic is chronic migraine in primary care. Basically, we'll be talking about chronic migraine diagnosis and treatment, and with some emphasis on the role that primary care providers can play in this condition. I think we have a lot of primary care doctors on the line, but we do have a number of other primary care providers. Here are my disclosures. I do some consulting work with a number of pharmaceutical companies that are active in the headache field. I'm going to start off with a few words about what migraine is. Migraine now is considered to be an inherited disabling neurological condition. And it does more than just cause head pain. It causes a lot of sensory sensitivity to the environment. For example, the light sensitivity that many migraine sufferers have during a migraine attack and sometimes even between attacks. It causes other symptoms that are neurological in nature, like the migraine auras with visual symptoms, sensory symptoms, speech disturbances. Basically, ultimately, a migraine is genetic. But, and of course, the genes determine our biochemistry. So I often tell patients that the cause of their migraine attacks is basically a part of their chemistry. Many factors can influence how frequent and severe migraine attacks will be over a person's lifetime. So the genes don't determine everything, and the environment is also important. For example, stressful situations can make migraine attacks more frequent. This is one example of that. Basically, a migraine is a neurological condition in the same way that other things are, like Parkinson's or sclerosis or stroke. Now, one area where migraine is really unique among neurological conditions is how common it is. This graph shows the prevalence of migraine in the percent of the population on the left, on the vertical axis, and we have age on the horizontal axis. And you can see that when it comes to women, represented by the dotted line, you'll see that at age 40, for example, about over a quarter of women are experiencing migraine attacks. So this is an extremely common condition. That for men, the prevalence of migraine is much less, and for example, even at age 40, only about 7% of men have migraine attacks. So a very common condition. And you'll also notice that after menopause, many women lose their migraine attacks, but even by age 80, about 5 or 6% of women are still having migraine attacks. Now, our topic today is chronic migraine, and we'll define in a minute what that is. Chronic migraine is essentially the more severe end of the migraine spectrum. And you can see in this graph that chronic migraine is less frequent. About 8% of migraine sufferers eventually end up developing chronic migraine. But that's still a lot of people. And in essence, about 1% of the general population have chronic migraine at any one time. So it's still a very, very common condition. And again, like migraine, chronic migraine is more common in men than in women. And at about age 40, almost 2% of women will be suffering from chronic migraine. So our topic is the diagnosis and management of chronic migraine. And it's a complicated topic. I mean, first of all, patients with chronic migraine have headache most days. Some have headache every day. And so this has to be differentiated from headaches due to other causes, so-called secondary headaches, things like brain tumors or other conditions, and we'll identify some of these later. And, as you know, migraine is considered a primary headache type. That is, there's no other cause except for the patient's genetic makeup and their biochemistry. When it comes to treating chronic migraine, there's no single simple solution. I've listed 5 categories there, and patients need to consider lifestyle factors and avoiding migraine triggers for themselves. They'll often have to consider behavioral management, for example, stress management skills. Drug therapy plays an important role in migraine treatment, and this includes 2 categories, which are quite distinct: acute therapy for individual attacks and prophylactic or daily medication therapy to make their attacks less frequent. And finally, we have this problem of acute medication overuse, which we'll talk more about. And this is a big deal in chronic migraine because patients have such frequent headaches, and any medication taken for individual headache attacks, be it a painkiller, a triptan, a non-steroidal anti-inflammatory drug, medications are all capable of making migraine headache more frequent in patients with migraine if they're taken too often, that is, on too many days a month. Let's focus a little on diagnosis for a few minutes. And so I have a case here, which we'll run through together. This is a 30-year-old woman who has a history of intermittent headache attacks that are throbbing, last about a day and a half untreated. And she has, in the past, she had significant nausea with these attacks. And they were one-sided headaches. Now, for 2 years, she's had a headache on about 23 days a month. So she has headache on more days than she is headache-free. These headaches are now often on both sides. They're bilateral. She considers them to be of moderate severity. On about 12 days a month, though, she has flares where she has a more severe headache. And once again, they are mainly one-sided. They may involve either side, and they throb. And to try to cope with all this, she's taking sumatriptan, which is Imitrex, on at least 12 days a month. She's taking acetaminophen with codeine on about 8 additional days a month. So she's taking medication for her attacks to try to control them about 20 days a month. So the question is, what is her diagnosis? And I don't think we have the capacity to be interactive here, but I'll give you some options. And we'll discuss the diagnostic criteria for these conditions in a minute. So this is just to kind of whet your appetite. But you'll notice that the options we have are basically many of the causes of patients who have chronic daily headache or headache on more than 14 days a month. We have medication overuse headache there. We have chronic migraine, chronic tension type headache. Then we have the option of making 2 diagnoses, chronic migraine and medication overuse headache. And we have a thing called mixed headache. Now, I'll just mention that the last category, item E there, mixed headache was an old term, which we used to use for patients who have both migraine and tension type headache days or attacks. But that's no longer used, really. And this patient would fall into the category of having chronic migraine for sure. She has migraine. There's a history of past attacks of typical migraine intermittently, and now she has very frequent headache. And she also has medication overuse because she's taking some kind of acute medication for her headaches on about 20 days a month. So, diagnostic criteria. Here are the diagnostic criteria for chronic migraine. And you'll see that basically you have to have headache on at least 15 days a month. Some patients have headache every day. You have to have at least a history of at least 5 attacks of migraine in the past before your chronic daily headache started. And she certainly had that. And then now, currently, to make this diagnosis of chronic migraine, on 8 days a month, you have to have genuine migraine type headaches. In other words, not all the headache days have to be migraine in nature, only 8 do. The rest can be any kind of headache, and it may even be sort of typical tension type headaches, but if there are 15 days of headache and 8 days are migraine of these, then the diagnosis is chronic migraine unless some other diagnosis is obvious. So to diagnose those 8 migraine days that these patients must have, and many have much more, here are the migraine diagnostic criteria. So you'll notice that a migraine day or a migraine attack can be quite variable in nature between patients, and this causes diagnostic confusion. I mean, the patients with migraine attacks of migraine are typically between 4 hours and 3 days. You only need 2 of those 4 pain criteria, so the headaches don't have to be one-sided. They don't even have to throb. If you have headaches of moderate or severe intensity that are aggravated by physical activity during the attack, like climbing stairs, or make patients avoid those activities because it makes their pain worse, those last 2 criteria are sufficient. You only require 2 of those 4 pain criteria. You also have to have one of the associated symptom criteria. You'll notice you don't have to have nausea or vomiting. If you simply have light and sound sensitivity, photo and phonophobia, that's sufficient to diagnose migraine along with the 2 pain criteria. But of course, there must be no other cause apparent. So if the patient's got paralysis on one side and has a brain tumor, you wouldn't diagnose that patient with migraine. So the diagnosis of chronic migraine has evolved over the years, and now we're actually into the International Classification of Headache Disorders version 3. 3 beta is now obsolete. And you'll notice the important sort of changes in these last couple of years. First of all, if patients meet diagnostic criteria for chronic migraine, that excludes a diagnosis of chronic tension type headache, even though they may have more tension type days than migraine days. They have 8 migraine days and headache on more than 14 days a month, they have chronic migraine. And finally, patients who meet criteria for both chronic migraine and medication overuse headache get both diagnoses. So one doesn't exclude the other. Now, this presentation is based upon a publication about the care of chronic migraine and primary care. And this publication has algorithms. We're going to look at those now and just see how they work. Of course, an algorithm is a way to sort of help with decision making and making things very simple. So this algorithm starts off with a patient who has chronic daily headache. So this basically means headache lasting 4 hours or more on at least 15 days a month. And for 3 months, this is a chronic condition. The first thing you have to do is rule out secondary headaches. Now, usually we consider the history and physical to be sufficient to do that. Sometimes investigations like brain scans are necessary, and the current medical environment, we probably do far more brain scans than we really need to because patients are worried and doctors are worried. So if you are still concerned this patient may have a secondary headache due to some structural cause or biochemical cause other than the primary headache types, then if the answer is no, you have to consider those diagnoses and investigate, or if you're a primary care provider, maybe refer the patient for investigations. If a secondary headache seems to have been ruled out, then you proceed down the algorithm. But before we proceed further down the algorithm, I'll just show this slide, which is from the guidelines for the primary care management of headache in adults. And this is available to you all if you like. It's on the top website, or the Top Alberta Doctors website. So if you Google Top Alberta, these guidelines will come up. They're the headache guidelines, and they're in their guidelines section. And just to look at this very briefly, we have red flags, we have both emergent red flags and urgent red flags, and we have other possible indicators of secondary headache which are less urgent. And so, for example, a thunderclap headache is a emergent red flag. This could be a subarachnoid hemorrhage, and these patients have to be sent to the emergency as quickly as possible and investigated for that diagnosis and potentially others. The urgent red flags, well, if you have an older patient with a new headache problem who has also some mental changes, cognitive changes, that patient may have a chronic subdural hematoma and also requires fairly urgent investigation. Going down to the possible indicators, if a person has unusual headache precipitants, for example, their headaches are made much worse by standing up and basically go away when they lie down. That is, the headaches have a strong postural component. Then you might think about a spinal fluid leak, and those patients also require investigation, but this is not a urgent or emergent situation. And finally, if headaches are aggravated by neck movements, for example, when the neck examination is quite abnormal, you might consider a headache related to neck problems, and this, of course, is especially relevant in patients who've had recent whiplash injuries, and so they may have a chronic post-whiplash headache. So that's a few words on secondary headaches and when you might consider them and investigate. Moving back to our algorithm, assuming that we were satisfied the patient does not have a secondary headache, then we asked the patient about prior migraine attacks before their headaches became so frequent. Now, chronic migraine essentially always develops out of a past history of regular intermittent migraine attacks or episodic migraine. And so if the answer is no, they have no previous migraine history, and this history may require some digging to get, then you might again consider other diagnoses. And there are other causes of daily headache in the primary headache category that I've listed there. These patients may have chronic tension type headache or hemicrania continua or daily persistent headache. These are all other primary headaches, or they may even have a secondary headache syndrome, and they have to reevaluate whether they could have a secondary headache. So if the answer is yes, they do have a history of previous migraine attacks, then the question is, currently, do they have at least 8 days a month where their headaches meet migraine diagnostic criteria, or are successfully treated by a triptan or other migraine-specific medication? Now, you may need a headache diary to figure this out, but once you do, if they meet that criteria, then you diagnose chronic migraine. And once you've diagnosed chronic migraine, the question is, do they have medication overuse as part of their chronic migraine syndrome? And you'll see the limits there. The magic numbers are 10 and 15. If they're taking NSAIDs, like naproxen or ibuprofen or acetaminophen, some analgesics from 15 days per month or more, they're at risk for medication overuse headache. Or if they're taking triptans like sumatriptan or Imitrex or others, or opioids like Tylenol 3s, combination medications, Percocets, If they're taking those on 10 days per month or more, they're again considered at risk for medication overuse headache, and their medication overuse may be playing an important role in perpetuating their chronic daily headache syndrome. So you can see there that if they have medication overuse, you diagnose both chronic migraine and medication overuse. If they don't, you just diagnose chronic migraine. So that's the diagnostic algorithm. Now what about management? So you've diagnosed chronic migraine, and the first thing you have to do is explain the diagnosis to the patient, because patients are typically quite troubled or disabled by their headache syndrome, and they want some answers as to what's causing it. And then you have to discuss management, and part of this includes discussing behavioral factors which may be influencing their chronic migraine and making their headaches more frequent. Now, patients with migraine, especially chronic migraine, have a really high prevalence of coexisting or additional anxiety and or depression, so that may need to be addressed. And finally, the headache diary can certainly help sort things out in terms of the patient's headache syndrome, how frequent they are, how severe they are, and also what they're taking in the way of medication. So let's look at some of this. Explaining the diagnosis. Well, patients have to understand that if they have migraine, some patients this progresses to a chronic migraine syndrome. In other words, very frequent headache. And it's not rare. There are thousands of patients in a city like Calgary or Vancouver. This can be quite a problem for patients, and a number of things can make a patient with migraine, can make their chances greater of progressing to chronic migraine. I've listed some of those there, and that includes heavy caffeine consumption, obesity, a lot of stress, as examples. And on the other hand, addressing these issues can help to resolve chronic migraine. So behavioral factors that can help patients successfully manage chronic migraine. Pacing is an important one, and pacing simply refers to patients managing their schedules to avoid too much fatigue and stress. And they may have to be very careful with their schedules if other migraine triggers are operating. For example, in Calgary, we have these Chinook winds that come in, and they're a migraine trigger for a lot of people. And if that's about to happen, patients need to especially avoid getting too stressed out and fatigued, and perhaps make a few cancellations so their schedules aren't too hectic. I'll mention a few more here. And the migraine triggers, these include everything from food triggers like processed meats with nitrates and red wine, and they're very individual. Some patients have some have another. Some food additives like MSG, monosodium glutamate, is another frequent migraine trigger. These things have to be sorted out, and patients need to manage them as best as they can. Now, there are a number of important lifestyle issues. Managing stress is one of them, but also regular meals. A lot of migraine patients that I see in the clinic are still skipping breakfast, for example. Skipping meals is not a good idea for migraine patients. At the same time, you want to have good weight management, and you want to have regular exercise. I usually advise patients to reduce their caffeine, because caffeine is basically an analgesic, and therefore likely causes medication overuse headache in the same way that other analgesics do. And sleep is extremely important, and a lot of migraine patients have poor sleep hygiene, and they can be helped by improving their sleep hygiene rather than going to a lot of sleep medications. One question I often ask is whether the migraine patient has a television in the bedroom. If they say yes, I know they probably need some help with their sleep hygiene, because that's considered a no-no by most sleep specialists. The headache diary is also important, and you'll notice a website down below there. Again, the Top Alberta Doctors website, and there's a headache diary there as a resource. Patients can print this off, or health professionals can print it off. It's a paper diary, and there are a lot of apps around as well, which people can use. importantly, these diaries should record medication use, not just the presence of headache. And patients can also use them to see if they have a relationship to their menstrual cycle with their headaches, and even try to find potential triggers. So let's say a word now about medication overuse headache. In general, if patients with chronic migraine have acute medication overuse, this should be addressed early because it can be a major factor in perpetuating their chronic daily headache syndrome. So we'll say a bit about that, and part of treating medication overuse is also to start a prophylactic medication at the same time. So I'll give you an example of a simple case of medication overuse. This is a 58-year-old male we saw now a few years ago, and the history was that he had migraine attacks since age 12, my history, and now he had basically headache every day for at least 10 years. And he was taking for many years now acetaminophen and ibuprofen, fairly innocent medications on a daily basis. His family doctor had also given him a prophylactic medication, in this case amitriptyline, which he was taking, but he still had headache every day. So the question is, what is the single most important thing to do at this point? When I asked this question, I got a number of responses, but in my view, the answer is education of the patient. In this case, this patient didn't see one of us. He went to our education session in our headache program, and he learned that taking painkillers daily could make your migraine worse and result in basically headache every day. So when he heard that, he essentially stopped his daily medication use. And what happened was that his migraine reverted to the original intermittent attack pattern, and he began to have a migraine attack every month or two and lost his daily headache. He had an appointment to see the neurologist in the headache clinic, and he came to that appointment a few months later just to tell us he was better and the problem was solved. Now, like many patients who stopped their medication overuse, he had a rough week or two when he stopped the painkillers, but that exacerbation settled down after about 2 or 3 weeks, and then he was a whole lot better. So that's a very typical story for chronic migraine with medication overuse, but unfortunately, not all patients will respond the way he did. About half do. Excuse me, about half do, but the other half basically keep their chronic daily headache, but they aren't much worse or not worse at all, maybe even a little better. So stopping medication overuse is always worthwhile to do at least once in a patient. And stopping means a couple of months off the painkillers. We'll talk more about that because a good proportion will in fact get better. So how do you help a patient stop their acute medication overuse and migraine? And education is key. And you have to give them information on the limits. And again, the magic numbers are 10 and 15. 10 days a month of triptans or combination analgesics, any opiate is too much. And 15 days or more of simple analgesics or NSAIDs is too much. So you shouldn't underestimate the power of advice. Here's a study done in Europe, where it's a randomized controlled study and even double-blind. And basically, they randomized patients who were seeing their primary care provider, their family doctor in this case, either receive advice about stopping medication overuse because they had chronic daily headache, chronic migraine, or they were randomized to treatment like usual, which I gather in this practice setting that didn't really include a discussion of medication overuse and the effects upon headache. Again, the medication overuse issue is an issue primarily with migraine patients. For some reason, migraine patients seem to be especially prone to developing a greater and greater headache frequency with acute medication overuse. Now, you'll notice that this simple advice in a primary care physician's office resulted in considerable improvement in the patients as a group. Here's their headache days per month on the vertical axis. And I'm not sure if you can see my mouse on this presentation. I should have asked about that. Notice that after the brief intervention, 3 months later, that is, getting advice about stopping medication overuse and the important role this can play in chronic migraine management, notice that the headache frequency dropped from an average of 25 days a month to about 17 days a month. Whereas in the other group, on the right-hand side, the business as usual group, who weren't given this advice, their headache days per month did not change and stayed at about 25 days per month. Now, did these patients reduce their acute medication intake, their painkillers or whatever they were taking, their triptans? You'll see that they did. If you look at the left-hand side, the brief intervention side, their medication days per month went down from about 24 days to about 14 days, 13 days, and in the other group that didn't get the advice, their medication use days per month did not change. So never underestimate the power of patient education and advice. Now, it's a bit more complicated for some patients, and especially if they're overusing things like Tylenol 3s with codeine. You can advise a patient to stop acetaminophen and non-steroidal anti-inflammatory drugs and triptans abruptly. If they're taking opioids, you may need a taper, a gradual withdrawal. They will have severe headache attacks, probably, because they're migraine sufferers, and they may need to have something for those attacks. And you can provide something with limitations on frequency of use. If they're using, say, acetaminophen, you can give them a triptan. If they're overusing triptans, you can give them dihydroergotamine or DHE. That's a little complicated. They have to take this as a nasal spray or as an injection, a self-injection. There are things that you can do, but above all, these patients require some support and follow-up. They need to be encouraged because they may go through a few rough weeks before they begin to improve, especially if they're overusing medications containing codeine. At the same time, a prophylactic medication can be helpful, begin to improve their headache syndrome. And normally we start this at the same time as we're withdrawing the acute medication. This has been looked at in a systematic review, and I won't belabor this, but it does seem like preventative medications should be started at the same time as you're withdrawing the acute medications. And so if you want to look at a standard of care from this systematic review, they say to stop the overused medication in a patient with chronic migraine and medication overuse, but either start a preventative medication or start some biobehavioral therapy, like stress management and cognitive behavioral therapy, or if they can do both to help them through the difficult medication withdrawal period. So to summarize medication overuse, basically patients need education, you need to stop their overuse, you need a prophylactic medication in most instances, you need something to treat their severe attacks, but they're going to suffer somewhat during this time of withdrawal. They need careful follow-up and help with what they're going through. So let's continue down the algorithm. And so if you've diagnosed chronic migraine and you've dealt with the medication overuse, these patients do have frequent headache. We can't treat them all with acute medications because then they will get back into medication overuse. So they're going to all need some kind of pharmacological prophylaxis, probably, unless you're very successful with behavioral treatments. And so which prophylactic will you choose? And there are some decision points here. I mean, if their patient is quite overweight, you may want to go straight to topiramate, which tends to cause weight loss as opposed to weight gain. If the patient has a lot of insomnia, you may want to go to a tricyclic like amitriptyline or nortriptyline because those do help with straightening out their sleep. If the first prophylactic isn't successful, you may want to try the other one. So all patients respond to the first prophylactic or even the second prophylactic for that matter. I'll just point out that prophylactic medications and migraine, including chronic migraine, for the most part, they aren't ideal. And patients must understand that they must take the medication daily. A lot of patients have trouble with that, they forget. They must understand that the prophylactic medication or preventive medication won't abolish their attacks completely. The reduction of 50% is considered worthwhile by most people. If patients don't understand that, they may be very disappointed and discouraged and stop the prophylactic. It may take time for benefit to occur. It doesn't always happen in the first month. And it's an important matter of dose. Most of these medications are titrated up slowly. So when it comes to chronic migraine, the two most evidence-based prophylactic medications are topiramate and monobotulinum toxin A. Trade name is Botox. The other medications have much less evidence for their efficacy in chronic migraine as opposed to episodic migraine. The two conditions are somewhat different in their responses to prophylactic medication. But amitriptyline, as you can see, is still there for chronic migraine, lower down the list. Beta blockers, which are big players in episodic or intermittent migraine attack prophylaxis. There's very little research in chronic migraine, and I think in general they're less effective in chronic migraine than they are in episodic migraine. So again, we generally start these medications at quite a low dose and build up gradually over weeks. It applies to amitriptyline, it applies to topiramate. And if you start them off at full dose, patients experience a lot of side effects and they'll want to stop them. So the prophylactic medications that we have today are not always effective for patients, and that's especially true in chronic migraine. And so the question is, what do you do when the things you try fail, like amitriptyline and topiramate, perhaps some others that you've tried? And at that point, obviously, it's really time to consider referral of the patient to a headache specialist or at least to a neurologist, whatever is available in your area. One of the reasons for that is that a commonly used prophylactic now in chronic migraine is monobotulinum toxin A or Botox. Now, this does require injection, and there's a defined protocol which has been defined by research. So it requires some training to administer the Botox properly. And but the monobotulinum toxin A is helpful for a lot of chronic migraine patients, and I'm just showing you some data here from the Preempt trial, which are there were two big research trials in Botox and chronic migraine. And see, the upper line is the placebo response, and the lower orange line is the response of the active treatment group that got the Botox. You'll see these lines are separate. The first 6 months were double blind, and all patients got Botox in open label fashion after that. You can see that at the 6 month time point period, for example, the 6 month time period, the patients who got the Botox had 40 hours of headache per month less than the placebo group. People often say, well, the placebo group did really well in this study, and it's remarkable how big the placebo response was, but you know, a 40-hour improvement with the Botox over the placebo response is really quite significant. I mean, that's actually a whole work week for a lot of people per month where they're headache-free as opposed to having their chronic migraine. So certainly this response was both clinically and statistically significant. Now, the Botox is problematic in the sense that it requires about over 30 injections around the head and neck. The idea is to desensitize the pain nerves, so the injections are spread over a large territory in the front of the head, the sides, the back, the cervical spine, and the upper shoulders. And the point is that although a lot of patients do respond to the first treatment cycle, let's look at the right-hand panel. You can see treatment cycle 1. And in these studies, about 49% responded. That is, they lost about half their headaches, 50% or more of their headache days. But the second cycle, and this is given every 3 months, so the second cycle resulted in 11% more responding, The third cycle resulted in another 10% responding. So the point is that you almost need to give 3 injection cycles over 9 months then, every 3 months, 1 cycle, to see if the patient will respond to Botox in a significant way or not. So it's basically a 9-month treatment trial for some patients before you really want to give up and throw in the towel. So this is given by injection, as I mentioned, and the dose is between 155 and 195 units. It's got a standardized injection protocol called the Preventive protocol, and so that does require training. There's very little in the way of side effects. People do get brow ptosis sometimes. The eyebrow sags down, or the eyelid can sag down. Of course, that's always temporary, but it can be usually avoided by careful injection technique. Patients get neck pain, but there really isn't much in the way of systemic side effects. So in that sense, it's better tolerated than many of our oral prophylactic drugs. Now, how does this work? Well, the sensory nerve endings take up the Botox. It's transported to their central terminals. It seems to, well, it does reduce the release of many neurotransmitters that are involved in pain, so it kind of desensitizes these nerves. They also seems to regulate some of the receptors and ion channels in the cell membrane. So again, that can affect the pain system. Finally, although the pain and migraine comes from the dura in the skull, many pain nerve fibers have branches both in the dura, and they have a branch going through the skull, through the sutures primarily, through vascular channels, to the scalp. So injecting Botox in the scalp has the potential to influence nerve cells directly that also innervate the dura with their other branches. So we're learning more and more about the sort of rationale for why unbotulinum toxin A seems to be effective in a lot of patients with chronic migraine. So we're kind of in the summarizing mode now. Now this is directed at primary care physicians, but we'll run through this briefly because other primary care providers can certainly assist with this, and see that when it comes to chronic migraine, because it is common, 1% of the population, certainly neurologists and headache specialists can't really treat this whole population effectively. It is important that others participate in this. And so the first thing is to make a correct diagnosis and exclude secondary headaches. We've discussed that. It's important to initiate therapy, and this requires understanding what the patient is taking, addressing medication overuse if necessary. It involves discussing migraine triggers and lifestyle factors which may aggravate migraine. And of course, the diary issue can be important to have the patient keep a diary to try to understand their headaches better. In addition, people have to address anxiety and depression if it's present. One has to consider prophylactic medications in patients with chronic migraine. They basically all need it. And behavioral therapies are important, like learning stress management and relaxation techniques. And they often are not available enough to our patients. Then if the patient has seen a specialist and got a treatment plan, it's very important for primary care providers to reinforce this plan, because compliance with medications, for example, taking them properly is a big issue for migraine patients. And patients do slip back into medication overuse not infrequently if they aren't careful. There's always the question of when to refer, and I've listed there issues like marked disability, response to therapy, and atypical clinical features as factors which may want you to refer to a specialist. I'll just point out that are there some predictors of success in treating chronic migraine? Success usually means the patient getting back to an episodic migraine pattern. In other words, having fewer headache days per month. And there are 5 things listed there. One is lower baseline headache frequency. So if the patient has 16 days of headache per month, the prognosis is better than a patient who has, say, 25 headache days a month. So it's important to get patients early before they get into the real daily headache pattern. And whether or not patients take their prophylactic medications properly is important in prognosis. Whether they have been successful in withdrawing their overused acute drugs, if that was a factor in their headache syndrome. Exercise is also important and needs to be encouraged. And finally, sleep is also important. So having the patients learn about sleep hygiene and using that knowledge is an important prognostic factor in how well chronic migraine patients will do. So with that, I think this is the last slide. And the primary care physician certainly is critical in identifying and treating chronic migraine and starting therapy. Ideally, you want both pharmacological and non-pharmacological approaches. And in Canada, patients often don't have the kind of access that they need for non-pharmacological approaches. So it's really, to treat chronic migraine as well as possible, it really should be a team-based approach with physicians and other allied health personnel helping to support the patient and basically address this condition from many different angles. With that, I'll stop and I'll welcome any questions which you might have.
Thank you. To our audience, if you have any questions at this time, please enter them into the question box on the GoToWebinar panel, and we'll read them out loud. So some questions that came in: if a patient comes in complaining of chronic migraines with no genetic history of migraines, can they still be diagnosed based on these criteria, or would you be hesitant to jump to these conclusions? Perhaps have them start with a headache diary?
Well, so the genetics of migraine is interesting because we've been trying to define the genetics for decades now. And although there are some rare syndromes that are monogenetic, that is, there's a single gene mutation that causes them, like hemiplegic migraine, that is infrequent. And for the great majority of migraine patients out there are many genes involved in their migraine. So it is quite possible to have no family history. Most patients do have a family history, but it's quite possible to, as a child, to get a mix of genes that makes you migraine prone, but neither parent showed that. So a lack of a family history does not in any way preclude a diagnosis of migraine or chronic migraine. I suppose it might make you a little bit more vigilant and looking for other headache causes, but the answer is this is a polygenic condition. The genes get shuffled and reshuffled with our parents and us, and you may just get a bad deck even though your parents were low threshold. Or maybe you become, maybe they were migraine prone too, but maybe not quite as much as you, and maybe you had a tougher life. Maybe you have more stress, or something happened that made you more migraine prone, some environmental exposure of some sort. I hope that answers the question.
Another question that came in: can you comment on the link between weather change and migraines?
Well, I can. A lot of migraine patients report that weather changes will trigger their attacks. In the past, research has been sort of negative. It's been hard to show statistical correlations, but that is changing slowly. You can imagine that many migraine patients have a number of triggers, and these triggers can add up, so that if one trigger isn't enough to cause your headache, the presence of a second one, they can summate to put you over a threshold. So sorting out these triggers is not simple. For example, if a woman has a greater migraine tendency premenstrually, that may be a time when a trigger can easily, an additional trigger can easily cause a migraine attack, whereas that same trigger may not be successful in causing an attack at other times during the hormonal cycle. When it comes to weather, some of you may know, we did some research on that in Calgary. We looked at the probability of our migraine patients having headaches when the Chinook wind came in. Now, that was fairly easy because the Chinook weather system has a very abrupt onset. within an hour, the temperature may rise 5 or 6 degrees, and the wind may pick up, and the Chinook is there. So with a nice point to do migraine attack correlations with, we did find that quite a few patients in our study, about a quarter, were sensitive statistically to the pre-Chinook day when the barometric pressure is falling, so maybe that's the factor. Another quarter seemed to be more headache prone during the Chinook wind itself, if the wind exceeded 38 kilometers per hour, which can cause changes in ion concentrations in the air, more positive ions, which are kind of negative for health. So with half the patients we studied, we could show a increased headache probability with the Chinook wind, some the day before, some the day of the wind. Don't ask me how this works, but obviously these weather systems can change your brain chemistry, I would think, maybe through the sympathetic nervous system and the immune system. We know that arthritic patients complain of joint pain exacerbations in the same way with weather changes. And probably many weather changes can do this, but it's harder to prove with other weather change types. I was on a talk show in Kelowna one time in BC, and a lot of patients called in Kelowna and said, weather changes are a big factor for me here in Kelowna. So it isn't just the Chinook winds, obviously, that we have in Calgary. Other changes as well seem to affect patients a lot.
Okay. What do you recommend clients look at when trying to find a headache migraine clinic? Multidisciplinary team, educational classes, and do you have any recommended clinics in the Toronto area?
Well, you have a number of headache specialists in Toronto. I mentioned a few. There's Dr. Lay at the Women's Hospital, whatever it's called now. It's got a longer name. And there's Dr. Jonathan Gladstone, who has a private clinic in Toronto. Just to mention two, perhaps. So, basically, most patients with headache and with migraine are referred to neurologists if they need help beyond their primary care providers. And the neurologist would know what's going on in the area. Again, access to allied health professionals is less than it should be in Canada. We have big systems in place for getting drugs to patients, but when it comes to getting the help of allied health professionals, our Medicare system is much less attuned to that, and we have to change that for migraine patients.
Mm-hmm. In the 9-month Botox treatment trial, does the patient require maintenance Botox, or do the benefits continue after the last Botox injection?
Yeah, so that's a good question. The hope is that by getting the migraine toned down from 25 days a month to maybe 6 or 7 days a month, that the migraine will sort of settle down and the Botox won't be required forever. The kind of patients that we're referred to in our clinic, a lot of patients, in fact, seem to require the Botox for years. And when the 3-month period starts to come to an end, their headaches begin to come back, and they're very glad to come in for another Botox cycle. Now, some patients, you can increase the interval to 4 months from 3 months, and then even 6 months, and eventually get patients off them. It's hard to know if the present evidence is how often that happens, but quite a number of patients seem to require the Botox for some years. Eventually, the patients may lose their migraine. They may become menopausal, for example, and the migraines will get less. So it's not totally clear what proportion of patients can actually stop the Botox, but certainly some can.
Mm-hmm. Is there more information regarding a woman's menstrual cycle and impact on migraines? Does treatment differ for this population?
So some patients will have menstrual migraine where their attacks only occur with dropping estrogen levels just before their period starts. Others will have attacks during the month as well, but have their worst attacks at that time. Other patients, the menstrual cycle doesn't seem to influence the headaches very much. Now, there are things you can do if a menstrual attack, that is usually, I should say, the premenstrual attack, the day before the period and the early part of the period. There are things you can do to address that specifically. And one thing you can do, for example, is take a triptan like triptan, which is a long half-life triptan. You take that on a regular basis, starting the day before the patient's menstrual headache vulnerability, which is often a day or two before the period starts, and taking that medication twice a day for about 6 days. We don't recommend daily triptans normally for migraine, but as a sort of mini prophylaxis in that time of the premenstrual window, that can be helpful. You do have to time the period, and that's hard for many women unless they're on the pill. Now, if you're on the pill, then you can actually take the pill continuously if your doctor approves that for 6 months or a year and abolish your periods, and that way, again, avoid the menstrual migraines.
Another question. I often find my patients end up on a combination of riboflavin, coenzyme Q10, and magnesium for migraine prevention. Is there any evidence to support their use?
Yes, all three of those have controlled trials which support their use. And so they're all recognized migraine prophylactic medications. And if you go on that Top Alberta website, you can learn a little more about that. You can Google migrainecanada.org, which is a patient-focused website, and there's more information there as well. Now, those are prophylactics. They're not terribly strong prophylactics, but they do have a measurable effect, and you can certainly try those before trying actual drugs if the patient would prefer that. They do have very few side effects.
Are headaches with migraine features and aura, which started after a concussion, treated the same as chronic migraines?
Well, when it comes to post-traumatic headaches, like concussion-related headaches, there's very little research in that area. The dogma is that if they resemble migraine, you treat them like migraine. So the answer is yes. Now, head injuries can certainly affect migraine patients quite severely. They may actually initiate migraine in some patients. These patients may have had a migraine tendency that hadn't become manifest before that. Or if they have had migraine attacks, they may become much more frequent after a head injury. In other words, they can convert to chronic migraine very quickly with a head injury, even a mild head injury. So yes, you treat them like migraine.
Okay. I think we have time for one last question. We did have some questions come in after the time, so we'll see if Dr. Becker can answer those in a follow-up email. For a non-pharmacological approach, do you recommend acupuncture?
Well, I guess the answer is yes. Acupuncture has been shown to have a migraine prophylactic value. The only problem is that in many studies, sham acupuncture, that is acupuncture done wrong, work just as well, but both work better than waitlist controls. So it does have an effect. Now, whether that's all placebo, people argue about that, but it certainly has an effect in these studies. Some recent studies suggest that acupuncture may have benefit even over so-called sham acupuncture, although that difference seems to be small. People are still arguing about it, but acupuncture does seem to help migraine patients, whether it's primarily placebo or something more scientific and profound, I guess, is the question.
Well, that's all the time we have for questions at the moment. Dr. Becker, is there anything you'd like to add following your presentation?
Well, I would just add perhaps that I know we have many different kinds of providers online here, other than physicians. I guess if you're seeing patients with migraine, I'll say two things. First of all, a lot of migraine patients will complain of neck muscle tightness during the attacks. That's part of the migraine attack and doesn't mean that they've got a problem in their neck, which is actually causing their headaches. It's kind of an epiphenomenon. Second thing I'll say is that ask patients what they're taking. If they're taking even plain Tylenol, acetaminophen, more than 14 days a month, the medication overuse may be a factor in making their headaches so frequent. The patient may not realize that, so all of you can perhaps help patients understand that medication overuse, acute medication overuse, is not good for chronic migraine sufferers.
Well, thank you so much for your webinar, and thank you for your time in presenting today.